Tonight's program is being brought to you by Dr. Nicholas Short, Assistant Professor of Medicine at MD Anderson Cancer Center in the Department of Leukemia. The topic is treatment of pH-positive ALL in the modern era, looking at TKI selection as well as the impact on the role of stem cell transplantation. Dr. Short, I'll let you go ahead and begin.
All right. Well, thank you all for joining. Thank you for the invitation. So, as mentioned, we'll be talking really about modern therapy of Philadelphia chromosome positive ALL, and we'll focus on some of these key, I would say, debates and also paradigm shifts we've seen in the field in the last few years. So, these are my disclosures. So if we think about general principles of treatment of Philadelphia chromosome positive ALL, obviously we know that addition of a BCR-ABL tyrosine kinase improves survival compared to historical with chemotherapy alone. Of course, we have various TKI options, and really the question is, how do we choose among them? Ranging from first generation imatinib to third generation TKI ponatinib. And what I'll show over the course of this talk, what I would argue is that what we've seen is that with these later generation TKIs, particularly with ponatinib, we've seen higher rates of molecular response, which we know is associated with better survival in pH-positive ALL. And I think the availability of these better, more potent TKIs, as well as other therapies such as blinatumomab, as we'll discuss, has led many to question what's the role of intensive chemotherapy for these patients? Can we use lower intensity regimens or even chemotherapy-free regimens? And also, what's the role of transplant in first remission now? Historically, the standard of care was intensive chemotherapy followed by allotransplant for everyone, but I think that's really changing, particularly over the last several years. So just to start with kind of where this began, so this is a study really showing most conclusively that addition of a TKI to chemotherapy improves outcomes in pH-positive ALL. This was done by the group in the UK, and what they found was as they changed and switched over and added imatinib to patients with pH-positive ALL, they found higher rates of remission and also better survival. And a couple important points. One is that they found that early introduction of imatinib was better than even later introduction. So it shows that when you have a patient with new pH-positive ALL, as soon as you make that diagnosis, you need to be adding the TKI on, which I believe is most are doing as standard practice. And also, it showed that even in the new era, the new TKI era, there was still a benefit to stem cell transplant. So the standard of care was still, was now using a TKI in the frontline setting as early as possible, but still sending patients to transplant in first remission, specifically allotransplant. Then there was a number of subsequent studies. We did at MD Anderson a study of hyper-CVAD and imatinib, and then a study of hyper-CVAD dasatinib, and then that was later taken up by the SWOG group, evaluating in a large multi-center study, looking at hyper-CVAD plus dasatinib. So this was evaluated in patients up to 60 years of age with newly diagnosed pH-positive ALL. The 3-year overall survival rate was around 70%. And importantly, they asked the same question, now that we have a more potent TKI, dasatinib, do we still need to transplant patients? And the answer was, at least if we don't select patients for MRD and we don't ask any of those other questions, if you just take, broadly speaking, the patients enrolled on the study, those patients who went to transplant did better than those who did not. So suggesting that if you treat a patient with hyper-CVAD dasatinib, all other things being equal, they should be referred for stem cell transplant. So we don't have a lot of randomized data comparing one TKI versus the other. I'll be talking about the Falcon study in a bit, about showing the imatinib versus ponatinib, but this is one study in children evaluating imatinib versus dasatinib in children with pH-positive ALL. They were randomized to receive chemotherapy with imatinib or dasatinib, and what you can see was an improvement in event-free survival as well as overall survival with dasatinib. And this was driven largely by lower rates of CNS relapse in patients who received dasatinib. And this is consistent with what we know, which is that dasatinib penetrates better into the blood-brain barrier, and so it protects from CNS relapse. So this is, until the Falcon study, which we'll discuss, this is the really only randomized data that we had to suggest to compare one TKI versus the other in pH-positive ALL. So what's the problem with imatinib or dasatinib? Well, we still see relapses, and why do we see relapses? Because we see the development of T315I mutations. So these mutations confer resistance to really all of the commercially available TKIs except for ponatinib. And they're detected in about 3/4 of patients at the time of relapse when they're treated with a first or second generation TKI. These are data specifically from patients treated with low intensity therapy with dasatinib. And so that's led our group and others to ask the question, well, what's the potential role of ponatinib in the frontline setting in Ph-positive ALL? A TKI that's active against these mutations and potentially can prevent their relapse by suppressing these clones. So we did a study of hyper-CVAD plus ponatinib in Ph-positive ALL. So this is standard hyper-CVAD, given for 8 cycles. Initially, we gave ponatinib at 45 milligrams daily continuously, and there were 2 fatal myocardial infarctions. So we subsequently amended the study to start with 45 milligrams, decrease to 30 milligrams once patients achieve a CR, which is essentially all patients after 1 cycle, and then further to 15 milligrams once patients achieve a complete molecular response. With that regimen, with that dose modification, the regimen is much better tolerated, and it really decreases the cardiovascular toxicity associated with ponatinib. After the 8 cycles of intensive chemotherapy, patients receive 2 years of maintenance with vincristine steroids and ponatinib. And then we try to treat patients for at least 5 years of maintenance of any TKI, specifically ponatinib, after that. We were doing 12 doses of intrathecal chemotherapy, which we found that decreased the rate of CNS relapse in patients with Ph-positive ALL. So these are the outcomes versus the MRD outcomes. So we saw that overall, 86% of patients achieved a complete molecular response, meaning absence of detectable PCR for BCR-ABL. And this translated to a 5-year overall survival rate of 74%. So if we contrast this with data from our own studies internally with hyper-CVAD imatinib and hyper-CVAD dasatinib, we saw 5-year survival rates of around 40 to 50%. So this seemed to be a significant improvement upon historical data with earlier first or second generation TKIs. So what's the role of transplant when patients are treated with hyper-CVAD plus ponatinib? So we did a landmark analysis. First of all, I would point out that we only transplanted a minority of patients, only about 1/4 of patients, and we did select patients for transplant, those who did not achieve a complete molecular response. So they are enriched. It is a worse risk population for sure. But importantly, we could see that despite not transplanting around 80% of patients, those patients who didn't undergo transplant in first remission actually had very good long-term survival, had an 83% 5-year survival rate. So it suggests that we can use MRD to identify patients who may or may not need transplant. With hyper-CVAD ponatinib, we had very high rates of MRD negativity, and we were able to spare most patients transplant, and they would still have very good outcomes. So in the absence of randomized data, at least at the time, we did a propensity score analysis comparing hyper-CVAD ponatinib to hyper-CVAD dasatinib. This is when you compare, it's not only a retrospective analysis in aggregate, but we match patients as well as we can for baseline characteristics to account for any differences in heterogeneity. And we saw a very clear improvement in event-free and overall survival. And this was driven by higher rates of MRD negativity in the ponatinib group. So I've talked a lot about the importance of MRD in Ph-positive ALL. Just to really illustrate this, this is an analysis that we did looking at patients with Philadelphia chromosome-positive ALL treated with hyper-CVAD plus a TKI, either imatinib, dasatinib, or ponatinib, who did not undergo transplant in first remission. And then we evaluated their outcomes according to their MRD status. And then what we found was that among these patients, again, none of them went to transplant. The 4-year survival rate for non-transplanted patients who achieved a complete molecular response was 66%, which is relatively good in a non-transplanted population, versus around 30 to 40% for patients who did not achieve a complete molecular response. Complete molecular response was the only factor that was prognostic for overall survival. And we looked at various time points and found that a complete molecular response at about 3 months into treatment, which is about 3 to 4 cycles of hyper-CVAD plus TKI, was the most important time point. So we've used this in our own internal algorithms, this 3-month complete molecular response rate as a decision point in terms of whether or not we would recommend patients for transplant or not. I think an important question then was, does it matter, is all that matters is that the patients achieve a complete molecular response, or does it matter how they get there? And so what we did then is we said, okay, well, we've shown that a 3-month complete molecular response is important in pH-positive ALL. But does it matter what kind of TKI the patient received in order to get that response? So we took all patients who achieved a 3-month complete molecular response and then evaluated the difference in outcomes according to the TKI received. You can see here that despite achieving the same MRD response at the same time point, those patients who received hyper-CVAD with ponatinib did better than those who received either hyper-CVAD, imatinib, or dasatinib, suggesting that not only is the response endpoint important to predict survival, but also the TKI, again, highlighting the potency of ponatinib in pH-positive ALL. And just to finally highlight this point, this was a large analysis, a multi-center study, looking at the impact of a complete molecular response at 3 months, again, which we've shown was very prognostic in pH-positive ALL, asking the question, among patients who achieve this response, do they benefit from stem cell transplant? And the answer is no. So transplant, as is always the case in these analyses, generally does decrease the risk of relapse, but this was counterbalanced by a higher rate of non-relapse mortality. And in the end, there was no impact of transplant on overall survival or relapse-free survival, which is really what we care about. And this suggests, again, that for patients who achieve a complete molecular response, after about 3 months, those patients generally do not need to undergo transplant in first remission. So this leads us to, again, deciding on what type of TKI should we use. I think I've already shown you a lot of data, retrospective data, suggesting that ponatinib is probably better than imatinib or dasatinib. And this is a randomized study, the Falcon study, which was just recently, the data were just recently reported, that asked this question. So patients were randomized with newly diagnosed pH-positive ALL to a low-intensity chemotherapy backbone with either imatinib or ponatinib, imatinib 600 milligrams daily, or ponatinib 30 milligrams daily. Interestingly, the primary endpoint of this study was MRD negativity, or so basically a complete molecular response. In this case, it was at the end of induction rather than the 3-month that we talked about. And this was agreed upon by the FDA as well. And of course, we'll need survival data in the end, but this was the primary endpoint to decide on the success of the trial. So what you can see here is that the ponatinib arm was associated with a clearly significant improvement in the primary endpoint, which was MRD negativity at the end of induction. Oh, MRD negative CR. So patients needed to be in CR and also MRD negative at the end of induction. So 34% versus 16%. And also MRD negativity in general, whether or not they were in a full CR. Improvement, a doubling in the ponatinib arm versus imatinib. And so here you can see the MRD negativity rates by cycle. You can see that with ponatinib, it increases over time to the point where by the time you get to cycle 7, cycle 9, essentially 90% of patients are in a complete molecular response, as opposed to with imatinib, it kind of peaks around 50%. So we're able to achieve a higher cumulative rate of MRD negativity with ponatinib than can be achieved with imatinib. So obviously, we want to know the longer-term implications of this. I've already shown you data suggesting that MRD negativity is, potentially a surrogate for these important survival metrics. The follow-up is still short in pH-positive ALL. We need to look out, 3, 4, 5 years. The median follow-up is still only 20 months, but we can start to see what looks like a separation of the curves with event-free survival in favor of the ponatinib arm. But again, the study is not yet powered to show this potential improvement. So adverse events, this is an important question because the main concern, like why would we not use ponatinib, is the potential risk for cardiovascular toxicity or other things, pancreatitis, blood clots, et cetera. And so the study actually showed that at this dosing, again, 30 milligrams of ponatinib, which I think is much better tolerated than 45, 30 milligrams of ponatinib, you actually can see very well-balanced adverse events between the two arms. And I think what do we care about the most is these arterial occlusive events and the venous thrombotic events. So here you can see the AOEs, these are the arterial occlusive events, the VTEs, the venous thrombotic events. And actually, there was no difference between ponatinib and imatinib, suggesting at least with this dosing schedule, starting at 30 milligrams rather than 45, we see relatively balanced important adverse events between the two arms. providing more data that we can safely go with the more potent TKI, in this case, ponatinib. Okay, so moving on to, aside from TKI selection, what about the backbone regimen? Do we still need intensive chemotherapy? This is the DIALBA study published in the New England Journal of Medicine that evaluated a chemotherapy-free regimen of dasatinib and blinatumomab in patients with Ph-positive ALL. They enrolled patients of all ages with newly diagnosed Ph-positive ALL, treated them initially with a run-in of dasatinib and steroids for about 3 months, and then introduced blinatumomab for up to 5 cycles, along with central nervous system prophylaxis. So these are the data that were initially published in the New England Journal now about 3 years ago now. So 63 patients treated. They achieved a complete molecular response around 60% after 2 cycles of blinatumomab. And you can see very encouraging early overall survival and disease-free survival, although we need longer term follow-up. And the group has reported updated data just in the about a year ago at the last year's EHA. They've transplanted half of the patients. There have been 9 relapses out of the 63, so still a relatively low relapse rate. Interestingly, 5 of the 9 were extramedullary, which is higher than we might expect. And several of these were in the central nervous system. This is something to consider with these chemotherapy-free regimens. And the 4-year overall survival rate was 78%. So still very good outcomes with a chemotherapy-free regimen, really on par with what we expect with a chemotherapy plus TKI regimen. I think the question is, can we improve upon this? And so what we've done at MD Anderson is have done a study of ponatinib with blinatumomab in Ph-positive ALL. We start the blinatumomab, and compared to the DIALBA study, we started right in the very beginning. So patients receive 30 milligrams of ponatinib along with blinatumomab, 5 cycles of blinatumomab. Once patients achieve a complete molecular response, we decrease the dose of ponatinib to 15 milligrams. And we have been, at least until recently, been doing 12 doses of intrathecal prophylaxis. I'll talk a little bit about, we've now increased that to 15 because of a concern for CNS relapses in patients treated with chemotherapy-free regimens. These are the response rates. Essentially, all the patients have responded. There was 1 early death, but all evaluable patients did respond, had a CR/CRi. The complete molecular response rate overall was 83%, and 2/3 of patients achieved a complete molecular response after just 1 cycle of treatment. Now we also use the clonoSEQ assay, so with this next generation sequencing MRD, which is even more sensitive than PCR. You can see 89% of patients achieve this overall, 45% of patients after just 1 cycle of treatment. We can see very early MRD responses. So actually, after just 2 weeks of treatment, we can see that so after 2 weeks, half of patients have cleared their PCR, have essentially achieved a complete molecular response in the peripheral blood compartment. So very rapid responses despite a chemotherapy-free regimen. So this is the disposition for the 60 patients. There was 1 early death, as I mentioned. 2 patients died in CR. There have been 4 relapses, 2 in the CNS, 1 extramedullary, and 1 in the bone marrow. Only one, I think this is an important point, only 1 patient was transplanted in first remission. And so what we believe we see is that we can see a regimen that can overcome the need for transplant in first remission in Ph-positive ALL, similar to what we saw, as I showed you, with hyper-CVAD plus ponatinib. And the rest of the patients are in ongoing response without transplant. So these are the survival outcomes. The event-free survival, 2-year event-free survival, 79%. 2-year overall survival, 88%. And again, importantly, we see this 2-year overall survival of 88%, despite only 1 patient being transplanted to date. And so here is the survival outcomes that we've seen at our institution over the years. And this kind of highlights, I think, what we've seen with the changes in treatment for Ph-positive ALL. So in the pre-TKI era, obviously the outcomes were dismal. Those were significantly improved with the introduction of imatinib, but interestingly, we did not really see a significant improvement in outcomes when we then moved to dasatinib. However, once we introduced ponatinib, we saw a significant improvement in overall survival for patients with Ph-positive ALL. And then now in the new chemotherapy-free era, where we now treat all of our patients with newly diagnosed Ph-positive ALL with chemotherapy-free regimens with blinatumomab and ponatinib. We need longer-term follow-up data, yes, but we can start to see what looks like, what might be a new era in terms of improvement in outcomes for patients with Ph-positive ALL. So with that, I will conclude just to highlight that Ph-positive ALL, I would argue, is now actually a relatively favorable prognosis in ALL, whereas historically, and actually in some consensus guidelines, they still call it poor risk, but actually that's one of the types of subtypes that we actually are happy when our patient is diagnosed with because we have such good treatment options for. Ponatinib-based therapies are associated very clearly with higher rates of complete molecular response. And the retrospective data suggests that this is associated with higher cure rates and less need for transplant. We're now moving more to chemotherapy-free regimens as a newer standard of care with either dasatinib or ponatinib in combination with blinatumomab. We see reduced toxicity when we move away from intensive chemotherapy, and I would argue with equal or perhaps even superior efficacy. In the study of dasatinib and blinatumomab, they still transplanted half of the patients, so it's not entirely clear whether or not these patients need to be transplanted routinely or not. But I would argue with ponatinib and blinatumomab, where we've only transplanted 1 out of 60 patients and have very encouraging survival, that this is a regimen that can overcome the need for transplant in certainly the vast majority of patients. And with that, I will conclude. We have some cases, but I'm happy to take any questions now, but then we'll go into the questions. There is one question in the chat, so feel free to either message the chat or unmute yourself and we can discuss. So the question in the chat, oh, this is a direct message, but I'll answer it. So when looking at various TKIs, did you factor in the patients with IKZF1? Will they do worse with imatinib and dasatinib anyway? So this is a good question. So what is the role of molecular alterations in Ph-positive ALL? Does it inform what we should do as consolidation therapy, transplant or not? I don't think we fully know this. Certainly we know that there is this phenotype called IKZF1 or Ikaros plus. So these are patients who have an Ikaros deletion in combination with another abnormality, usually CDKN2A or B or PAX5. Those patients across a number of studies do worse. In the DIALBA study, they found with the dasatinib and blinatumomab, they found that those patients did worse. We're going back in the ponatinib and blinatumomab study to evaluate these characteristics to see if that might predict for outcomes, but we don't have those data yet. I would not use that. I think now that we have very good MRD monitoring tools, both PCR and I would always use the next generation sequencing MRD, the clonoSEQ as well. I think we can use those and monitor very carefully and usually decide on the need for transplant based on that. There is another question about if we do maintenance TKI or maintenance ponatinib in this case for 5 years, how often do we check the PCR? I check a PCR every 3 months in patients with Ph-positive ALL. After finishing initial therapy, let's say they're treated with blinatumomab and ponatinib, or whatever your regimen is, and then they're in a maintenance phase, I would check it more frequently in the first year or two. So I might do alternating bone marrow every 4 months or so, honestly. Although we have good peripheral blood tools, maybe bone marrow every 6 months. But in between that, I'm going to get a peripheral blood PCR and clonoSEQ at least every 3 months. And then after someone's been on therapy for 5 years, I might check a little less frequently, maybe every 6 months or so.
Can I ask a question? Can you hear me?
Yes, go ahead.
Thank you so much. I have a question about, there are some patients who are NGS negative, but still have some persistent PCR. I know you just published an article about this, but would you, that says that they have good outcomes, even if they're persistently positive on the PCR, would you stop maintenance after 5 years in those patients, or you would continue that indefinitely?
So that's a great question. So yeah, this is an area I have a lot of interest in, and this is something, if you do send both the PCR and clonoSEQ, which I do for all my patients, you will see this phenomenon. There's about 20% of patients with Ph-positive ALL who have something that some have coined the term CML-like biology. Essentially, even though they don't present as a CML lymphoid blast phase, they don't have a history of CML, they still have persistent PCR that's likely for BCR-ABL, that's likely coming from the non-lymphoid component. And it's not really true MRD. So for example, I wouldn't transplant a patient who has low-level PCR, but it's clonoSEQ negative, because the clonoSEQ is really more specific for the leukemic clone, versus PCR for BCR-ABL tells you about the BCR-ABL transcript, but doesn't tell you where it's coming from. Your question is, but to that point, so that's just the phenomenon. Your question is, what would I do with those patients with the TKI? Those patients, I'm very hesitant. I would not stop the TKI. We don't know what to do with them. We don't know the leukemogenic potential of this background CML state. There was a recent report suggesting in children that where they'll stop the TKI in children, even if their PCR is still elevated, which is not what we do in the adult world, but they've described some very late relapses in patients like this after when they've been off a TKI. So I just treat it more like, at that point, I treat it like a chronic phase CML, right? We're not going for TFR, we're just treating it. So even if someone has low level PCR and they've been on a TKI for 5 years, I'm just going to continue that. I'm going to feel more confident about that. For someone who's PCR negative and clonoSEQ negative after 5 years, I think there's a good chance that we've eradicated all of the disease. And I would feel okay with stopping the TKI after 5 years. But it's always a discussion with the patient. If the patient is really hesitant to stop the TKI, I say, look, I don't have a lot of good data. Okay, as long as you're not having toxicity. But I'm definitely open to stopping the TKI for patients who are negative by all of our MRD assays after 5 years of maintenance. Other questions in the chat on blinaponatinib, how long would you wait to see MRD negativity before going to transplant? So again, I rely more on the clonoSEQ than the PCR. So I would want to see them be clonoSEQ negative by 3 to 4 cycles of the combination, basically. I'd be nervous if they're not, and if we really feel like it's real disease. Sometimes you get these assays that are less than low level of detection, and it's not always clear if it's real, if it's just background noise or not. But if it's real MRD that's persisting after about 3 to 4 cycles of blina, I would move on to consider transplant. We honestly don't see that very much. We really see very good rates of MRD clearance, but it certainly happens in rare patients. And then do I track both in the peripheral blood or intermittent bone marrow? In patients with Ph positive ALL, I'm usually alternating bone marrow and peripheral blood because we do have good peripheral blood MRD assays, both with PCR and the clonoSEQ. And then there's another question. Oh, I didn't talk about it, but yeah, or briefly mentioned it, increasing the number of intrathecals. So we have seen just, I would say, proportionally more, even though the rate of relapse in these chemotherapy regimens is still very low, we see proportionally more CNS relapses than we saw when we gave intensive chemotherapy. So I think that, and because we've removed the high dose, if we give hyper-CVAD, for example, we've removed the high-dose methotrexate and cytarabine, which really, in addition to the standard IT chemotherapy, which is, let's say you do 12, you're also getting CNS prophylaxis with high-dose methotrexate and cytarabine, which we've now eliminated if we give a chemotherapy-free regimen. So our plan now is we've now increased the number of intrathecals to 15. So if you're doing something like a blinatumomab and ponatinib, it's 3 per cycle for the 5 cycles. Whether or not that will be enough to overcome this higher, at least proportion relative risk of CNS relapse, we don't know. There's always a consideration, do we need to go back to some high-dose methotrexate and cytarabine, maybe for younger patients with Ph positive ALL? I think that's an open question. We just need longer-term data to answer that. But that's the rationale for increasing from 12 to 15. And then follow-up question about ITs for 15. If using mini CVD with lower doses of methotrexate cytarabine, would you also increase to 15? So in Ph positive ALL, if they get intensive chemotherapy, I do 12 ITs. If they get low intensity therapy, including mini hyper CVD, or they get chemotherapy free, I do 15. We're not really talking about Ph negative in detail today, but if we go to talk about Ph negative, if someone gets Ph negative ALL and they get full intensity chemotherapy, I do 8. If they get a lower intensity regimen, if any of you use like a mini CVD, INO, or things like that, I do 12, because I do think that we're just kind of increasing the number of IT doses of chemotherapy for anyone who's not getting full intensity CNS penetrating methotrexate cytarabine. And there was a question about giving blinatumomab inpatient. So for patients who are starting therapy with newly diagnosed ALL and even they're starting blinatumomab, yes, we give it inpatient. We do keep them in the hospital for the first month. I think it's reasonable to keep them in until you've done your dose escalation. So you start at 9 and you do it for a week, and then you escalate, and then you watch them for a couple of days. And if they do well on the 28, and you watch them, I think it's reasonable to discharge them after that. But yeah, I would always keep the patient at least through the dose escalation. And we really keep all patients who are undergoing, at least our institution, frontline new diagnosis induction therapy, even if it's not an intensive regimen, we typically keep them in the hospital, but it depends on age and other factors. When will blina become commercially available in this setting? There's probably not going to be an approval for blinatumomab in the frontline setting like this. But it's supported by NCCN guidelines, so usually you can get it through insurance. But it's true that, yes, it's not approved. Okay, and then can I speak about definitions of MRD negativity and complete molecular response for Ph-positive ALL? MRD negativity, okay, so for Ph-positive ALL, MRD negative is considered MR4, but this can be confusing and hard to keep track of when studies talk about MRD negative or CMR. Also, NGS, what level is considered negative? So for NGS, I consider negative like negative. I guess below, the only thing is if you get the NGS assay, sometimes they'll say below level of detection, and there is an art to interpreting it. Sometimes if you're tracking 3 clones and 2 are negative and 1's below LOD, I don't consider that real disease, but I do watch it. But you really want the clonoSEQ to be negative. Below LOD maybe at the most, and then to negative. For Ph-positive ALL, it is a little complicated. It depends on the sensitivity of the PCR assay. In general, MR4 is adequate if it's paired with a clonoSEQ that's negative. So because it really depends on the assay, and various groups and studies have defined it differently. Usually, if it's less than 0.01%, that is an adequate response. Certainly, if you're looking at the 3-month complete molecular response, 0.01% at 3 months is good. These are all excellent questions. Please, we will definitely have time for more. Let's go to the cases, and then there may generate more questions. But then, yes, let's please go back and go over more of these if you have them. Okay, so case 1. So this is a 19-year-old Hispanic man diagnosed with Ph-positive B-cell ALL. Now, this is a very interesting case. I was very interested to read this case. A patient who has Philadelphia chromosome-positive ALL, but also a CRLF2 rearrangement, which is Ph-like. This is very, very rare, but we do see it rarely. Shown on FISH, it was a P190 transcript, clonoSEQ without any dominant sequence identified, so I guess they weren't able to track. Was treated with essentially ponatinib and blinatumomab chemotherapy-free regimen, 12 lumbar punctures, and then went to transplant. They were getting monthly PCRs, which were not detectable, and I got post-transplant ponatinib. So I think everything here is very good. Even 1 cycle of post-transplant blinatumomab. You can see the chimerism there. But then, unfortunately, I guess this is what, like about how long after transplant? I'm just looking. About 6 months post-transplant, patient relapses, CNS disease. Interestingly, Philadelphia chromosome negative, so very, very rare, and then is now undergoing an induction therapy. So I don't know if anyone whoever had this case has anything to add, but it's very interesting. But we can talk about.
That's where we are. I'm waiting to see about the CRLF2 FISH and hoping to get a clonoSEQ this time to follow.
Yeah, so it's very interesting. So I would point out because it's relevant. So if you look at the patients that we had relapse, we treated 1 patient with this phenomenon, which is very rare, on blinatumomab, and they were one of the ones who relapsed. So the first one here, they actually were Ph-positive and had a CRLF2 rearrangement, and they relapsed in the extramedullary compartment, Ph negative, very similar to your patient after about 9 months. So very, very similar. Yes, this is a rare phenomenon, but one that we do see. I think that you treated this patient very well, but I think something that a decision that we made after this case was if we see this again, we would give them, and one of your questions was, should we give them chemotherapy? So yes, in retrospect, I would have given this patient chemotherapy, even though we don't typically do it for pH positive ALL, just because it's a very rare circumstance, and we've seen these patients behave more aggressively. And I mean, how often do you see pH positive ALL that relapses with pH negative disease? It's only this rare type that we've really seen this in. So yeah, in ideal world, I would have given them chemotherapy. But I think otherwise now, yeah, I agree, get the clonoSEQ so you can track it later. They're probably going to be CRLF2 rearranged, I would guess. What do we do now? For one thing, I guess I would say, I would continue the TKI, 15 milligrams of ponatinib, even if they're negative, because we don't know if that clone is there at a low level and persists. Because the last thing you want to do is eradicate this CRLF2 clone, but then they relapse with the other. So just like 15 milligrams of ponatinib.
We're holding it right now with the asparaginase on board. But
I think that's fine. I think that's fine. I mean, I think ultimately the goal would be to get it back on. But I think, yes, I agree, it's fine with asparaginase. I think it's a tough one. I will say anecdotally, the patient that what we did for our patient is we gave them CAR T cells, and they've been doing great. They went into a great remission, and they're still in remission. And I don't know how long it is afterwards. Maybe it's another 9 months later. So I would get them. I don't know what we have done this, and I know this isn't common practice because it's not on label, but we have gotten approval. We have given patients induction like this, and then CAR T cell consolidation. That would be what I would do if you can get it approved through insurance. Once refractory, I would just say they're always refractory. So you just say patient has refractory ALL and needs CAR T cells, because I don't think a second transplant, they relapse 6 months later. I don't think a second transplant is going to be the most helpful thing. I would get them into a remission with this. If they're MRD positive, even more so, you can argue to maybe do the CAR T cells. But we've done CAR T cell consolidation, and it's been effective in this, at least anecdotally.
Yeah. Thank you.
CAR T from the recipient themselves, or would you get the donor and do it? Collect the donor?
Oh, so yeah, so just allogeneic CAR T cell with their cells. I mean, with their cells, as long as they can have enough lymph. I mean, you have to use theirs. I mean, as far as I'm aware, do you do it? So I'm assuming they have enough lymphocytes circulating, you could just collect them. And it's actually a good time to collect when they're in remission, because when they're relapsed and all that, it's really hard to coordinate all this stuff. You get them into remission, you do some consolidation, collect them. At the very least, no matter what, collect them for CAR T cells. Even if you don't do it as a consolidation, this patient might need it later on, and then at least you can give them the CAR T cells if they relapse in the future. But I would try to do it as a consolidation like we do for transplant if you can get it cleared by insurance.
Okay.
But yeah, very interesting case, and very unfortunate, and one that we have seen before. Oh, and the CNS disease, what's the status of the CNS disease?
Actually, it's not that bad. Well, considering that he had so many spinal taps and TBI, but he only had a few cells on the first spinal tap. He only had the second spinal tap now, so I think he'll clear it. So
Okay.
The question is, how much CNS disease is that really?
Yeah, I don't know. We still do. I think to be on the side of caution. And we have seen, again, we saw our patient relapse with extramedullary disease. So I would think it's real, but if they clear, we do our twice a week until they clear, and then weekly, and I would just taper it off. But yeah, I would give them more CNS coverage.
I was thinking at least we would give him, like I have him on a pediatric protocol, so I would give him the 4 high-dose methotrexate consolidations, maybe after we collect the CAR T cells.
Yeah, but are you doing IT chemo or no?
Oh yeah, we're doing 4 ITs during induction.
Okay. I mean, I think just I would definitely address it with, if you're doing high-dose systemic therapy, that's great, and then with IT chemo, and I think if you do that, and it sounds like it's minimal, I think it's fine. One thing is I would just add is we always send, I don't know if everybody does this, but we always send flow. We do pick up on some cases where the flow lags behind, and we do use that to determine clearance. And it is more sensitive than just the cytology. Excellent. Okay, well, that was a very good case. Okay, we have another one. And so Dr. Edwards, this is your case. Do you want to tell us about it, or do you want me to? I'm happy to read it.
Go ahead, feel free.
I'll read it. Okay, I'll read it, but you add anything, or I might ask you if there's anything that comes up. Okay, so 55-year-old man, 2007, presented with splenic rupture, had pH positive B-cell ALL, was treated on the SWOG protocol. Is it, and by this, do you mean, what did they get? They got with dasatinib, or what TKI? Did they get, this is a while ago, but did they get they got a TKI?
I don't know, actually, I'm not sure.
Okay. But anyway, they got treated. They had some complications with induction. At some point, they were BCR-ABL positive, started on dasatinib, and then the decision was made, I guess, that maybe this was persistent disease or MRD. So they went to transplant. Sounds like did overall okay, had a few issues, but then really like 13 years later, this patient has a very late relapse of pH positive. It sounds like pH positive ALL, high white count. So very late relapse, something we see, but still unusual. Positive for CD19, CD22, BCR-ABL positive. And then one of your questions is, we have a large number of mutations/deletions. What do we do with these? So we see Ikaros loss. That's something we commonly see. We see loss of CDKN2A and 2B, which that together makes the IKZF1 plus genotype, which we know is associated with worse outcomes. Although this patient's relapse, so what is the significance in that context? I don't know. And so what would we do as the treatment plan? So to answer your first question, I don't know what others do. I don't know. I don't feel like we know enough about how to use this information, especially with these newer regimens. If we are giving ponatinib in the frontline setting, if we're giving chemotherapy-free regimens, I'm certainly very cautious about these patients, and they need very close MRD monitoring. But I don't use and do anything differently based on these genotypes, although they are, I think, probably clinically relevant. I don't know if they are enough to sway transplant versus not. I guess, does anybody else want to say, do they use this? Do they make decisions on transplant based on this, or do they just get these data and they don't know what to do with it, which I think is very common?
I really just threw in there as more of a controversial question when we're seeing all of these molecular,
Yeah,
so many diseases now. AML, we're just seeing, multiple markers that have some probably just heterogeneity or some
yeah. Yeah, I mean, I think for your patient, I do think that there are at least a few of these are clinically relevant. Again, maybe not to the point where it would change treatment, but I think they should have. We would expect a worse prognosis for a patient with a loss of IKZF1 and loss of CDKN2A and or B, which this patient has. But so that said, what should we do for this patient? So, I would argue, I would basically treat this patient like newly diagnosed pH positive ALL. I know that they're relapsed, but with a 13-year, just like in, if you have an AML or these acute leukemias, the longer the duration of remission, the more they behave like a new diagnosis. Now, that said, I would, with the caveat, I would keep in my mind that this patient still has relapse disease. But I think this would be a reasonable. Let's see. Let me just I'm reminding myself. Oops. Oh, sorry. Lost. They're 55, right? They had one prior transplant, but the transplant was such a long time ago. I would consider treating this patient with either blinatumomab and ponatinib, or what we've done as well is hyper CVD with blinatumomab and ponatinib. Or you could just treat them with hyper CVAD ponatinib, but I would give a blinatumomab consolidation. This is kind of making up regimen a little bit, but you just take the principle where hyper CVAD ponatinib is very effective. We have randomized data, not in pH positive ALL, but the blinatumomab in pH negative. The blinatumomab is very important regardless of MRD. So I would include it in the regimen. But then I think really the question is, regardless of what you do, blina ponatinib, blina dasatinib, although I always use ponatinib, mini CVD with ponatinib, with blina, hyper CVAD, ponatinib, blina. Do we transplant them again? And that's a hard question. I would, just because of this patient's history, I would consider, once they're in a really good remission, I would consider, we don't like second transplants for ALL, but when it's 13 years later, I would feel comfortable. I would probably refer this patient for transplant. I don't know if anybody has any other thoughts, because I don't think there's definitely not a right or wrong answer. It's a very interesting case. But yeah, I would consider definitely a blina ponatinib based regimen in some way, maybe with some addition of chemotherapy.
What if the patient still has their graft?
I don't think that really, I personally wouldn't affect what I would do. I mean, they have grossly relapsed disease. We just need to get them into remission, and then I think question like, could you do like DLI or something like that?
I think that's what Felix is asking him, would
Yeah.
your DLI
I
is
mean,
what-
the thing is, even though we transplant patients with ALL, obviously we think that there's some graft versus leukemia effect. We don't really feel that there's much graft versus leukemia effect, which makes us really not like DLI in this setting. I think if the patient said, I don't want transplant, I refuse to get transplant, they don't have any good donors, whatever, I think it would be a reasonable backup plan. But I would say for someone who was transplanted 13 years ago, I think it's not the typical patient where we say, oh, second transplant, I'm very hesitant to do. I think it would be very reasonable. It's like not their first, it's like their 1.5 transplants or something like that. It's not quite, because it was so long ago. But I think I would consider that, even though I don't usually transplant Ph positive ALL, this is a relapse case. This is, they have some poor risk genotypes. They've had a prior transplant a long time ago. I would err on the side, and this patient's still young, 55. I would err on the side of transplant if they're in good shape and if they have a good donor.
So we actually went the ponatinib blinatumomab and started on that with some steroids and the plan to give him additional intrathecals. And then we talked about doing DLI because he does have still mixed chimerism, and donor was a sibling, so it would be a lower risk DLI, but the donor may not be available, so we're not quite sure on that.
Yeah, I think it's reasonable to try and monitor. I would just be nervous, but I think as long as you're monitoring the PCR and clonoSEQ very carefully, I think it's a possibility. We have seen patients with relapsed refractory disease who we've given blinatumomab, depending on if they don't have a lot of high risk features or very late relapses, who've done well without consolidative transplant. But when I show the outcomes for blinatumomab frontline, and we do the same thing in relapsed refractory, the outcomes are much worse. And like I said, it is a unique scenario because I would expect this patient to behave a little bit more like a newly diagnosed patient, but I would still be nervous about them. So I think blinatumomab with DLIs and very close monitoring of PCR clonoSEQ is reasonable, but I would be ready to do another transplant if things aren't going in the right direction.
Would you throw in extra high dose Ara-C and methotrexate cycles into him for additional extramedullary protection? And the second question is, if he goes MRD negative after 2 or 3 cycles of just ponatinib and blina, and he's MRD negative a couple of times, would you just continue like a newly diagnosed patient?
It's a really hard question. It's a really hard question. I think it's an individualized decision. Honestly, what I would do is I would tell the patient, I would say, look, you're relapsed, but all the nuances. You're relapsed, but it's a long relapse. You have a great response, but we're kind of in uncharted territories to some extent. The standard of care for someone with relapse disease would be to send them to transplant. You already know what that's like going through it. Here are your options. We can do this. We can watch MRD. We can do DLIs, but I can't guarantee that you won't just suddenly. I mean, you just suddenly relapse. I mean, that's certainly very possible, right? Even with close MRD monitoring, it can happen. But maybe this regimen will be curative. You've never had these drugs before. You've never had a really potent TKI, because I'm assuming you didn't get ponatinib, right? That was a long time ago. Didn't get blinatumomab, obviously. You've never been exposed to these drugs before. I think he has a very good chance of responding and having a very good response. Whether or not it's going to be curative. Sorry?
Point of correction. He got dasatinib upfront.
Okay, yeah. But I mean, so he got dasatinib, but he hasn't had ponatinib and all that. Definitely ponatinib 30 to start with until you document the complete molecular response. I would have that discussion and say, look, I don't know. I would be open to either one. If a patient, sometimes you tell a patient you absolutely need a transplant, you're going to die without a transplant. I wouldn't tell him that, but I would say, look, I'm nervous about your risk of relapse, and just see what he wants to do.
Yeah, no, he's gung ho with whatever we need to do. He's still fit and active and was working full time and back to full speed, normal guy last time.
I think the most important thing is if you are doing the transplant, you get him into as good of a remission as possible. I mean, I would give him tell him, we're going to do this a little bit later. We're going to give you 3 to 4 cycles of blinatumomab, get you into a good response. I don't know the answer. I would he's relatively young. certainly no problem with adding a dose of high-dose methotrexate Ara-C, particularly if you're not going the transplant route, along with intrathecals. But yeah, I think that he has a potential to be cured without. We just don't have enough data. So it really depends. Is the patient comfortable with that plan, or are they like, some people say, yeah, give me a second transplant, I'm going to do just fine, I want to do it, and so you go for it.
He'd be fine with it. We would do reduced intensity conditioning for him anyway because of his previous BUSI, and most likely. And so he'd be up for it. We have been going down more the DLI pathway for our earlier relapses who are, not exhausted that pathway. But again, it's going to depend on whether his donor's available or not. If he's MRD negative, we might go the DLI pathway and just stay that way.
I think it's reasonable. You just have to very close monitoring, but I would be ready and tell him, look, if anything's not going in the right direction, we're going to be ready to do a transplant ASAP, because as soon as you start to see the MRD rise, you don't have much time before you need to move on to transplant.
Very helpful. You'll hear from us in a couple of months with updates on the data to further refine your suggestions.
Yeah, I would say the other thing, and this is also controversial, but this is also certainly not on label, but CAR T-cell consolidation, if you can get it cleared by his insurance. I think that would be I would feel much better with that as an option. Even though he's already had CD19 therapy, we've done it a lot, and we're still analyzing the data, but I think it's very reasonable, particularly for someone who wants to avoid second transplant. And I just say, hey, tell the insurance company, hey, this patient's refractory. Yeah, we have them in remission again, but they still have relapsed disease, and usually we get it approved.
Interesting idea.
Okay, excellent. So before we need to wrap up by 7, but I'm very happy to answer any other questions. Any other questions or thoughts on any of this?
Okay, let's go ahead and wrap it up. Thanks for a couple great cases. Definitely in the outlier realm.
Yeah, though very interesting cases, and I don't think a right or wrong answer for either one of them, but very interesting. So excellent.
Well, thanks for a great talk, Dr. Short, and thanks everybody for taking some time out of your evening, and I hope everybody has a pleasant night.
Thank you all. Have a good day. Bye.
Thank you.